Okay, so my name is Helena Grönqvist and I work in something that's called UCare that I will talk a little bit more about. And I'm a researcher and research coordinator, and we work with online delivery of psychological support. So we kind of try to find good evidence to implement in the healthcare regarding psychological support. And I will start by showing a film to give you some.
UCare-portalen är ett helt nytt sätt att samarbeta på. Det är en plattform där patienter, vårdpersonal och forskare kan arbeta tillsammans på ett helt nytt sätt som inte har funnits möjlighet till tidigare. Patienterna kan genomgå sin behandling var de vill och när de vill. Vårdpersonalen kan interagera och kommunicera med sina patienter på ett sätt som det inte funnits tid eller möjlighet till tidigare. Och forskarna kan designa sina studier och samla in data under behandlingens gång. Sjukdomar som cancer och hjärtproblem kan göra att man mår psykiskt dåligt. Många av de här patienterna får inte den vård de skulle behöva. Den psykologiska ohälsan skapar onödigt lidande, men även kostnader för den enskilda och samhället.
Du måste ha rätt verktyg till hands, och det verktyget måste vara tillgängligt. För tiden kommer alltid vara ett problem. I traditionell sjukvård så måste rätt person vara på rätt plats vid rätt tillfälle för att möta patientens behov. Om vi kunde hitta ett sätt där vi kunde jobba mer flexibelt och mer tillgängligt, så skulle vi vara en god bit på väg mot bättre vård. UCare-portalen hjälper oss med det här. Ett behandlingsprogram i UCare-portalen kan byggas upp med filmer, texter och övningar. Att kunna använda filmer för att illustrera en situation ger en helt annan upplevelse för patienten. Allt som vi har börjat vänja oss vid genom att vi använder internet så mycket, det finns som verktyg i UCare-portalen. Det finns diskussionsforum och chattfunktioner där patienter kan interagera med varandra. Och psykologen kan sedan följa behandlingen och interagera, kommunicera med patienten i portalen. Det som är så bra, det är att vi kan använda UCare-portalen varhelst det finns internet. Vi har jobbat mycket för att UCare-portalen ska vara lättillgänglig, lättanvänd men även säker. Inloggningen sker med dubbel autentisering, vilket innebär att man får en kod till sin mobiltelefon när man ska logga in. Dessutom är allting i portalen krypterat.
Vi märker direkt att det här är någonting som folk blir intresserade av. Man ser faktiskt möjligheterna. Och redan nu så har vi släppt in forskargrupper som använder portalen i sin verksamhet.
Patienten kommunicerar regelbundet med sin psykolog via portalen. Till exempel så skickar man in de övningarna man har gjort under veckan och så får man återkoppling på det. Och det här kan man göra när som helst på dygnet. Så passar det bättre på morgonen så gör man det, och passar det bättre på kvällen så gör man det. Och som studiedeltagare så fyller man också i självrapporteringsformulär, alltså frågor om hur man mår och hur livet ser ut. Och det gör man regelbundet, upprepade gånger.
Jag har jobbat med oro och nedstämdhet efter hjärtinfarkt. Och den behandling vi har består av texter, övningar och frågor som patienterna får ta del av. Och vi har också lagt in spelfilmer som illustrerar en del vanliga situationer som kan uppstå när man är nedstämd och när man är orolig. Och det här kan patienterna ta del av och fundera över och ge sin respons till oss kring. Jag går in varje dag och kollar vad patienterna har gjort för någonting, om de har tagit del av de övningar och genomfört dem som vi pratat om, och vad de skriver om det. Och all kommunikation som jag har sker ju via portalen. Det bästa med portalen är att man kan se vad patienterna har gjort för någonting, vad de har öppnat, vilka tidpunkter de har varit inne och arbetat, och att jag lätt kan ge dem feedback och sen få feedback på min feedback kring vad jag har skrivit till dem. Och den är bra designad på det sättet.
Vi studerar stegvis vård för personer som har drabbats av cancer, och vi skapar en studie på portalen som vi kallar för Adult Can. En sak som jag tycker är spännande med portalen, det är att vi kan se exakt vad besökarna gör och hur de använder materialet. Dessutom är allt material som vi lägger upp på portalen licensierat enligt Creative Commons, vilket betyder att andra forskare kan använda det som vi lägger upp och vice versa.
Portalen kopplar samman patientens, vårdpersonalens och forskarnas behov. Behandlingarna blir mer tillgängliga, Materialet som finns på portalen kan användas av andra för nya behandlingar på portalen och informationen vi samlar in kan hjälpa oss att vidareutveckla de här behandlingsformerna. Och portalen blir då biten som knyter ihop det här pusslet.
So, this is what we are developing right now, and I'm going to tell you more about it. So, I work in UCare, which is a strategic research program at Uppsala University, and around 2010 we were funded by the Swedish government to research the area of to try to reduce disease-related emotional distress. That is, that if you get a somatic disease or a physical disease, you sometimes experience emotional distress, and this needs to be reduced. We work interdisciplinary. Most of my colleagues are psychologists, but we also have from caring sciences, economics, and information systems that work together. And our target population at this time is children and adolescents diagnosed with cancer and their families. We have a lot for parents for these children. Adults diagnosed with cancer, and patients who've suffered from myocardial infarction. And traditionally in clinical research we have worked a lot from the perspective of the clinicians and the researchers, and we have switched this perspective now to try to look more, work more from the view of the citizen, and I will talk more about that in a while. So what we do in our research program is that we try to look at what psychological and economic consequences are there for having a somatic disease or a physical illness. And we've had 2 longitudinal studies following children with cancer and their parents for up to 10 years to see how is their emotional well-being over time. And we've seen that some of them really suffer up to 10 years after their disease is ended. And then we're trying to develop and test and evaluate different types of complex interventions to help them feel better. We also look at how we should design these online interventions in the best way to give them the best effect, and also how to design a sustainable system to support these interventions. And then also we look at other related areas. So, what the problem we had from the start is that we know that somatic disease causes psychological distress. And only very few of those people who gets this get the proper attention from psychologists. We have too few people who can help them in the regular care. And we know that it causes suffering to the human themselves, but it also creates costs. For example, if you have a depression, you're less likely to take your medication. So for example, if you've had a myocardial or a heart event, some type of heart event, and you need to take your medicine, and then you have a depression on top of that because of your heart event, you will be less likely to take your medication, and then actually probably need more care and not get better as you should. And it's also harder to follow other things, like for example self-care, as we talked about before. You will not do behavioral changes, you will not start to exercise more, you will not change your diet if you have a depression. So this is why we think it's a very important area to focus on. This is just a slide to kind of see how depression looks in different types of diseases. So in the general populations, we have a risk of depression that is around 10%. But if you look, for example, in cancer patients, it's somewhere between 25 and 30%. And pain patients is actually very high. They have a lot of emotional distress that is coupled with their pain. And the cardiac disease is also a higher risk. And as I said, there are evidence that the somatic disease will get less effective treatment if you have a depression on top of it. So this was our kind of start for our project. And then we said that what we want to have a system where we can try to reach these people at home, because we know we have too few psychologists, that we cannot treat them all. And for example, in the case of children with cancer, there are only 300 per year in Sweden. So to be able to reach them with good clinicians, the people, they will be scattered all over Sweden. So we have to have someone that can, so we can reach them. So we said, this is what we want to do, but how should we do it? Should we try to find or buy an existing portal where we can deliver and kind of research this? And what do we want? So we want the software that we can use in practice. We don't want a prototype. So we want something that we can use in our research studies. And we want it to be based on our needs in our organizations, but also on the users. And we want to log everything so we really can follow them very well. And we want support both for research and treatment. And there are other portals out there, but they are mostly for the treatment part. So we wanted to kind of have the research part included. So let's build it. We decided that it feels too complicated to find a system that that will kind of meet all our needs. Actually, we didn't really know our needs. We started out with the project, we got a lot of money, we were 5 people, or I wasn't involved, there were 5 people in the research group, and we knew we needed to do this thing, and they employed a lot of PhD students, thinking what do we need. Some of them had experience from internet treatment before, but some didn't. We started to work alongside with the Department for Information Systems, Information and Informatics and Media. And we had a researcher from there, and we also have now 3 PhD students there. And they started to build it, kind of listening into what the psychologist said. There was like a wish list, we want kind of this and we want kind of that, and started to work with it. And it was really hard because no one knew what to do, and there were some people from the heart event study said we want this, and then this person from the adolescent study said, oh, we want this, and then the adult cancer study said this. So we had no experience from this at all. So there was a lot of challenges, and we started with kind of a few not so detailed requirements, and it grew exponentially, and we had no one to decide how to do this. And we learned a lot during the process. We have first the group used Scrum, but I think it was maybe too immature. The whole group was too immature to kind of understand how to use it. So then it grew, and no one had the responsibility. But now, at this point, we're back to using Scrum, being very structured in our way of solving these problems. Have someone who is the project owner who can really decide what we should prioritize, and all these techniques that you probably learn here, they are very, very good to know. And we also saw a lot of conflicts. For example, in care and technology, we wanted to provide care. So we know from before that if you have a depression, there's good evidence that self-help will, or CBT or self-help will help you, and you can learn, and there are good interventions. But we didn't know how to put it online. There were some studies before, but they have kind of taken self-help books and just put them online. And then our researchers from informatics, they were really excited. They said, oh, you can use the technology in this way. You can use the chat here and this here. And the psychologist at that point, at least, was not really ready to kind of mix this, because they know we have to have something that we know works. What will happen if we add this? And no one knew what. So there was a lot of conflict, and we kind of, after a while, created a portal that we were satisfied with, and we said, okay, great. Now or the people from information systems, they think it's good, and we psychologists and researchers thinks it's good. Let's put it out there. And the first project that we started was was a feasibility for the teenagers with cancer. So we were very excited. We were finally done with our product. We'd worked on it for several years and super happy. And the psychologists had done a lot of materials. They had produced films and texts, and there was a forum and there was a chat and really everything for the user. And imagine our surprise that when we started to talk to the teenager and try to recruit them, really no one wanted to be in it. Their parents wanted them to go and have this, but they were not so interested. And the people who actually signed up, mostly because of their parents telling them to, they did not use it at all. And if they started to use it, they didn't keep on using it. So we were a bit, not so happy anymore. And we talked to our scientific advisors, and especially someone called Paul Fern, he's from Exeter University, and said, oh, you know, you need to talk to the users. I mean, we know that, really. It's not a big surprise, really. But we had been so focused on doing it from our perspective, and we have had users coming in and consulting them, but we hadn't really involved them in the research process. And, you know, accessing teenagers with cancer and asking them to be randomized into a study just after diagnosis. Maybe we should talk to them. Is this when you want your help, or how should we access you? Do you want someone, the doctor, to talk to you about this, or should it be maybe another teenager, or how should we do it? So we went to Exeter a couple of times to learn. We met their lived experience group and how they work together, and learned a lot from this. And then we came back. We knew we needed to learn more, but we also know we need to get this out now. So we recruited a teenage panel, and we talked to them. It was really hard to recruit them also to just this. So we had a mix of people, of teenagers who had cancer and non-cancer teenagers. And we started to talk to them, and we met them several times. And it was also not so easy to get these young people to find the right tools to get them to talk and to tell us what to do. But we actually we learned a lot from them. So they helped us redesign our homepage. We asked them, what do you want? What do you think is nice? Can you tell us a homepage you think is nice? And they told us like YouTube and Facebook. And we thought that they're not so super flashy, but it's the content. It's content driven in some way. So that's what they seem to. We need to have a content that is updated. But that also kind of is on the opposite from what we want, because we want them to work with the material for a long time, because that is what will help them actually with their depression and their emotional distress. So there's always a conflict how to find a way so they will work with the program that we need them to do, and that it's acceptable for them. So this the teen study will be starting in January actually now, so we will see if we have learned enough from that. But now what we are trying to implement is kind of a whole new way when we think. We have used something, the Medical Research Council's guidelines from the UK also, on how to kind of do this complex interventions. So we put a lot of emphasis on the starting phase, on developing, and we have employed, this is an intervention we are now developing for parents of children with cancer. So we've employed a parent who has their own child who have had cancer, and she is running the focus groups, and we are having a cyclical process. In the beginning, the psychologist said, oh, I have this, so at the first meeting I want to talk about the content, and at the next meeting I want to talk about the portal. And I said, oh no, so we've learned this. You cannot talk about the content and the portal in different sessions, because it's the same way, it's the same thing. You cannot deliver, it's not a book online. You have to think, how can I deliver this content in a way that will be accessible to these people? So should we show a movie with the same content? So we really have to start to think about it as one entity. So in short, what we have learned, we need the structured process. I mean, it's not something that is super news. You would know that this is how you should do it. But when you come to, it's not always easy to implement. And you have to have someone who decides what should be done, and you have to follow this process even though you get stressed. Otherwise, it will not work. We have to involve the public or the patients early on in the process, and not only to ask them about the content, but we're also asking them, how should we contact you? Is it okay to you if you are in our research program? Is it okay for you, for example, to be randomized to a wait list and not get your intervention for maybe 6 months? Is that reasonable for you to wait, if you're depressed, to wait 6 months to get you, so we can compare with the ones who get it now? Is that okay? Or should we wait 3 weeks, or what is okay with you? So we really have to also talk about the research process. So we also have now in our advisory board, we also have people from the public, so we don't do everything, just so we involve them the whole way. And also the thing that the material and delivery is one. But this is also, now I have my last slide here, but this is also a challenge, because if we treat material and delivery as one, we have a hard time keeping up with the new technology coming. It's changing all the time. When we started, actually no one was really using their smartphone or their iPad as they did today. So we said, oh, we will do it all on the PC. So everything was just for PC. And after a while, we saw that people are trying to log in on their iPhones and on their iPads, and it was a very bad experience. So we have had to redo the whole thing to also be delivered with mobile units. But then if we see the delivery and the program as one thing, and we evaluate that, and then there's a new technique or technology, do we have to redo the whole thing, or what can we say is working from what we are delivering? So this is a challenge that we're really facing and trying to find ways to solve. We are also having problems with legislation, of course. What can we do? We have the professor privilege, for example. That's one problem we have. So where the lecturers own their own material, but we want it to be open access to everyone. So we're trying to solve it there. We have problems with implementation. For example, if we send in an application for funding for a project like this, on average it takes 7 years before our paper is out with the evaluation of it. And then before we implement it in healthcare, it's up to, I think it's 17 years on average. So what happens from our idea until it's integrated in healthcare? It's a very long time, so it's not really relevant anymore. So how can we kind of speed this process up to get out relevant news and new technologies in healthcare? Yes, I think that's it. So there's a lot of challenges, and we need more people to help us solve it and do it faster, and still rigorous and and get good evidence for the future healthcare.
Excellent. Thank you. We have time for a few questions. There's a lot of sensitive information, I guess, that we're dealing with here.
Yes.
Are you able to,
Are we able
to keep the process secure?
Yes, that was a long process in the beginning. Our researchers from IM is especially interested in that and trying to find. We also have different databases and all the encryptions and where to store things. We store everything within Uppsala University, and so it's with all the corrects. But it's not easy to learn about all the legislation around this. And actually, we don't have any connection to healthcare. We are a research group researching health, and a lot of our colleagues are actually have double employment, so they also work at the hospital or something. But we don't have that. So when we wanted to start and give healthcare, the psychologists, they register psychologists, and if they do anything within their profession, they have to make journals or take medical journals. And where should they have that? Because we didn't know what to do. So after talking to Socialstyrelsen and a lot of people, we actually have our own healthcare unit within Uppsala University situated in our group, with the whole business around this, with someone who is responsible for it, writing all the papers and all the, so it's a lot of things to learn and to handle.
Okay, thank you. Thank you so much.